Okay, next slide. So there it is. Okay, today I will be going over opportunistic infection. I'm just going to go over opportunistic infection prophylaxis. This is obviously a very broad topic. So we're going to focus on the main three that we have historically prophylaxed against. So next slide, please. My only disclosure is I have served on the advisory board of Gilead in 2019, but that shouldn't affect anything we discussed today. So we're going to go over when to start opportunistic infection prophylaxis in patients with HIV, when stopping is appropriate, and then talk about the alternative, like the preferred and alternatives for each of them. And then as we go through, I'll discuss kind of medication considerations for each. So adverse effects, monitoring parameters, etc. Next slide. So pneumocystis jirovecii pneumonia, or PJP. Next slide. So this was the first kind of big opportunistic infection that made us aware of the AIDS epidemic in the 1980s. And so the CDC published their MMWR about gay men coming down with this rare pneumonia out in California, and suddenly all across the nation, physicians started going, well, that's happening here too. And it kind of prompted this search into what's causing these otherwise healthy young men to come down with such an odd pneumonia. So pneumocystis jirovecii is ubiquitous to the environment, but most of us have CD4 counts and immune systems that keep it in check. It can result from a reactivation or a new exposure, and prior to prophylaxis, an effective use of antiretroviral therapy was actually seen quite a bit in the United States. Up to 70 or 80% of our patients would end up diagnosed with it. We've had a substantial decline thanks to prophylaxis in ART, but it is still something that we see probably a couple times every year, often in patients that have fallen out of care or don't even know that they have HIV, and they present to the hospital and we diagnose them with PJP and AIDS at the same time. Most patients are aware into their status with low CD4 count, but of course, if somebody falls out of care, they're off prophylaxis, they're off HIV meds, they are also at risk. Next slide. So primary prophylaxis. So you want to initiate when the CD4 count is less than 200, or if they have a history of candidiasis. So the other consideration is a CD4 count of 14%. And I know that's not something that everyone looks at, but the guidelines do talk about a 14% CD4 count correlating to less than 200. And so if you have that low percent, even if their CD4 count is over 200 and absolute, it's worth considering it because they may be more immunocompromised than we actually think they are. The other consideration is if you have a CD4 count less than 250, but you can't monitor that patient every 3 months as is recommended, then you should also consider them for primary prophylaxis. I don't think we have very many patients in our clinic that fit this criteria, but it is something to be to think about if you have somebody that just maybe they can't come in every 3 months, maybe rural health limits them, transportation issues, then putting them on prophylaxis if their CD4 count is greater than 200 but less than 250. We're going to discontinue primary prophylaxis when their CD4 count is greater than 200 for 3 months and they're on antiretroviral therapy. The other consideration, this was changed in the guidelines probably about a year ago, is that if their CD4 count is greater than 100, that there's too many zeros on that slide, my apologies. If its CD4 count is greater than 100 and their HIV RNA remains below the limit of detection, so it's actually truly undetectable, then you can take them off of their primary prophylaxis as long as they've been undetectable for 3 to 6 months. And so what this is saying is if we have somebody well controlled on their HIV medications and their CD4 count just isn't responding, which does happen sometimes, then as long as that patient maintains a good viral load suppression, then you can take them off their PJP prophylaxis. And we actually did this, I think, last week with a patient. He's been on HIV meds for years and years. His CD4 count has been, 150, 175 for like the last, I don't know how many years of his life. And his viral load had been undetectable for well over a year. And so we just made the decision to go ahead and pull him off. He's super compliant, does everything he's supposed to do. His CD4 just won't recover. And there's nothing we can do to make it recover, no medications we can do to help it recover. But since he had always been undetectable and was super compliant, since he had that CD4 count that was greater than 100, and he had remained truly suppressed, undetectable for, in his case, well over a year, we chose to take him off of it. So that is a consideration. And the guidelines did change about a year ago. If you're concerned about it, though, you can wait for a CD4 count to be over 200 for 3 months. Obviously, if their CD4, can you go back one sec? If their CD4 count does drop to less than 200 with a detectable viral load, so this would, I think, most likely happen in somebody who's non-compliant, falls out of care, you want to restart, or if their CD4 count decreases to less than 100 regardless of viral load. And so I think this again speaks to the power and the importance of viral suppression in prophylaxis, is that every once in a while you'll see patients who sit on that hovering line that their CD4 count will drop to less than 200, but they maintain viral suppression. That as long as they're virally suppressed, you don't necessarily have to worry about it. Obviously recheck the viral CD4 count and make sure there's no other problems. But again, yesterday we had a patient who he complained of like an acute gastritis viral illness right about the time of labs. His labs prior had always been 300, and they dropped to like 180 with this set of labs, but he was completely undetectable and not missed any doses. And we did not initiate primary prophylaxis because our suspicion was his gastritis, just dropped his CD4 count, and he'll do fine. So we made sure we were going to repeat the CD4 count, obviously make sure it's not continuing to decline, but continue to watch him. So, but again, he was undetectable, and that's the important part, is that he was virally suppressed on his HIV medications. If he had dropped below 100, that would be a different story, and we would need to start him on prophylaxis. So next slide. Okay, so for primary prophylaxis, our first choice is going to be trimethoprim sulfamethoxazole or Bactrim DS at 1 tablet daily. You can do a couple different alternative dosings with this. So you can do double strength or single strength. However, the benefit of double strength is as long as they take it 3 times a week, they also have protection. And so that's good for patients that you're a little worried about compliance, but it's also beneficial because you can just dose it 3 times a week. And I'll kind of talk about in the next slide why I would do 3 times a week over once daily. Obviously, some patients have sulfa allergies, and at that point, then you need to look for alternatives. So dapsone is an appropriate alternative. Typically, we do the 100 milligrams daily because why would you give somebody a twice-a-day medication if you don't have to? And then atovaquone is also an alternative. I can tell you from personal experience, patients don't really like atovaquone. And then I have never used aerosolized pentamidine in my career, and I am going to try to very hard stay away from that. So it is in the guidelines, but I wouldn't necessarily recommend it as a go-to. Next slide. So medication considerations, we're all familiar with Bactrim. So you have some renal dysfunction issues that can occur there, and obviously potassium elevations. And so those are the people that I would consider moving to 3 times a week. So somebody who you start them on Bactrim and maybe their creatinine bumps, or you start them on Bactrim and you start seeing potassium elevations, you might, instead of just going to an alternative like dapsone, you might just check and see, can you decrease the dose to 3 times a week? And a lot of times in most of our patients that does the trick, and they're able to tolerate that. If you choose to use dapsone, do keep in mind that you can see hemolytic anemia in patients who are G6PD deficient. This is more common in patients of African and Mediterranean descent, and so it is worthwhile to check G6PD either before you start, or a lot of times we'll do it at initiation and then just follow up if we don't have a high suspicion. And then atovaquone, I mentioned patients don't really like to take it. It has significant GI upset with it. It is a liquid. I've never taken it myself, but I have been told by patients that it tastes awful. So just things to keep in mind. So I do try to avoid atovaquone if I can. Next. So Toxoplasma encephalitis. Next slide. So this is preventing the infection of the protozoan into the brain. It's usually caused by reactivation. It can be seen as an acute infection. But the times that we've seen it have always been a true reactivation. So this is the time where your IgG will be positive and your IgM will be negative. It occurs most of the time in patients, really when their CD4 count is less than 100, you can see it less than 200. And obviously the lower the CD4 count declines, the more likely you are to see it. Next slide. So all patients should be tested for their IgG of toxo at baseline to detect latent infection, and that will tell you if their CD4 count is low, if they're at risk for a reactivation of infection. So if an IgG is negative and their IgM is negative, then they have not been exposed, and you don't necessarily have to worry about it. But remember, patients can be exposed at any time because toxo is ubiquitous into the environment. So if they have cats, they're eating meat that's uncooked or poorly cooked, they can be exposed to it. So we want to initiate prophylaxis with a CD4 count less than 100 if they are seropositive. And we're going to discontinue if they are on effective antiretroviral therapy, CD4 count greater than 200. And again, this is because the treatment, or the prophylaxis is the same for PJP, we're going to discontinue at the same CD4 counts, etc. So next slide. So our preferred here is, again, Bactrim DS once a day. You can do it 3 times a week and still get coverage. Of note here, if you have to move on to the alternatives and you use dapsone, you also have to add pyrimethamine and leucovorin on in addition to dapsone to get appropriate coverage for toxo. So dapsone by itself will cover PJP, but if you need prophylaxis for toxo, you have to add pyrimethamine and leucovorin on. And the same is with the tobacone as well. Next slide. So just a couple of things to think here is leucovorin isn't actually doing anything in regards to the actual toxo prophylaxis, but it is restoring folate stores that the pyrimethamine is depleting. And so you do need both of those to prevent the side effects of pyrimethamine, but that leucovorin by itself isn't going to necessarily do anything for prevention. Pyrimethamine is limited to specialty pharmacies right now, and it is very, very expensive because pharma took it's an old drug that one manufacturer took over its manufacturing and ended up to the price several years ago. And so it's very expensive. It has to go to specialty pharmacies. So if you do have to prescribe pyrimethamine, just be aware that your Walgreens or your CVS, your Walmart down the street probably won't have it and won't have access to it. I know that around the Tulsa area, our Walgreens specialty pharmacy does have access to it. And I know OU Pharmacist Care Center also has access to it. Outside of that, I'm not actually sure who does. So just be aware of that. You may have to call around to a couple of pharmacies to actually get access to it. Next slide. So Mycobacterium avium complex, or MAC, is the next one. So these guidelines have actually changed, I think, since the last time I did this discussion. So MAC, again, it's ubiquitous in the environment, and so patients are at risk for it. Most common among patients who have a CD4 count less than 50. And if patients are not on antiretroviral therapy or prophylaxis, the incidence rate is actually pretty high. It's 20 to 40%. MAC is not something that we see a lot, but again, if we see it, it's usually coming in all patients who have either fallen out of care or are not aware that they have HIV. So next slide. So prevention. So this has changed within the last probably year and a half. We used to give primary prophylaxis with a CD4 count less than 50, but now the recommendation is prophylaxis for MAC is not recommended on patients who are able to immediately start antiretroviral therapy. So if you have a patient come into the clinic, or maybe they're in the hospital and you can immediately start them on antiretroviral therapy, you do not need to start them on MAC prophylaxis. However, you do need to start them on prophylaxis if for some reason they cannot start antiretroviral therapy and their CD4 count is less than 50. You do want to make sure that they don't have any mycobacterium infections in that process because the treatment or the prophylaxis includes one of the treatment drugs. And so we don't want to create resistance to azithromycin in the midst of all of that. So, but again, only if patients are not able to start antiretroviral therapy. We stop prophylaxis as soon as they start effective antiretroviral therapy. And so where I feel like I see this clinically and practically most often is somebody presents to the hospital newly diagnosed with HIV. They don't have MAC, they're really sick. They need but for whatever reason, maybe they don't have resources, they can't actually start HIV medications in the hospital and a follow-up. So they're scheduled with us in the clinic to come in, knowing that we'll start HIV medications. At discharge, the hospital will put them on azithromycin for MAC prophylaxis. They'll be on that until they follow up with us, and then as soon as they follow up with us and we start antiretroviral, we take it off. So that's clinically, I feel like, the practical way of where we see this. So, but if somebody just follows up, new initiation in the clinic for us, as long as we're starting antiretroviral therapy, we don't start MAC prophylaxis. Again, since we're not doing primary prophylaxis, you wouldn't really necessarily restart unless, again, their CD4 count drops and they're just not on antiretroviral therapy. Next slide. So I've alluded to this. Primary prophylaxis options are azithromycin, 1,200 milligrams. Can I be heard? Okay, it told me I got muted there for a second. So, so azithromycin is our preferred. You can do clarithromycin, but similar to dapsone, twice a day dosing. If you don't have to, don't do twice a day dosing. And the azithromycin 600, you can do, again, typo. It can be twice a week. So for patients that have, azithromycin has a lot of GI upset, especially at 1,200 milligrams at one-time dose. So you can do 600 twice a week. And so I usually tell patients, take it on Monday and Wednesday, or take it on Tuesday, Thursday. And we just discuss, like, what 2 days can you take this tablet, and tell them that they can do it then. As an alternative, if somebody does have true allergy, they can use rifabutin. Keep in mind, if you're using rifabutin for any reason whatsoever, there are a ton of drug interactions with it, and especially with HIV drugs. So be cautious of that. Next slide. Oh, and I already talked about this. So azithromycin has GI upset, and rifabutin is a pharmacist's either dream or a nightmare. I'm not really sure which some days, but there are drug interactions. So next slide. I think that may be it. Yeah. So summary: CD4 count less than 200, you need PJP prophylaxis. Preferred is Bactrim once a day. If your CD4 count's less than 100, you need to make sure that you have them on something adequate for toxoprophylaxis. Bactrim will cover it. And then MAC, you don't need primary prophylaxis as long as they are on effective antiretroviral therapy. So that concludes prophylaxis for HIV opportunistic infections. Are there any questions?